Hello, welcome to this week's concept map presentation. Today, we will be briefly covering the multiple pathology of imbalance. Please bear in mind that this presentation will not cover the pathology and management of each condition, but rather the identification of it. To understand why the patient feels disequilibrium, it is necessary to review briefly how the body regulates balance. Balance is maintained by upper cortex, brainstem, cranial nerves, spinal cord, peripheral nervous system, and its coordinating system. Loss of balance can arise from abnormality of any of them. Possible causes include frontal lobe pathology, normal pressure hydrocephalus, cerebellar stroke, Parkinson's disease, body-basilar insufficiency, B12 deficiency, Tabes dorsalis myelopathy, cerebellar degeneration from alcohol, multiple sensory deficit, dark environment, visual impairment such as cataract, peripheral neuropathy, diabetics, orthopedic disorder, medication such as benzodiazepine, tricyclic antidepressant, aminoglycosides. How the structure approach can be applied to the patient who feel that he or she might fall. Start with thorough history, past medical history, medication, risk factor for cerebral stroke or vestibular insufficiency, smoking history, alcohol, not just asking questions from a template, but actually using open and closed questions to give us the information we need to weigh up our differential diagnosis. It is then our responsibility as a good clinician to perform a thorough examination to gain the information we need to weigh out our differential diagnosis before coming up with the most likely causes of illness. The neurological exam, the cranial nerve exam, GAIT, sensory exam will provide the critical clue to the diagnosis. If it is normal GAIT, consider multiple sensory deficits. Stockings, glove sensory deficit are typical of diabetic neuropathy. If the GAIT is abnormal and white-based GAIT, consider cerebellar disease. If the GAIT is abnormal and shuffling, consider Parkinson's disease and look out for the other signs of Parkinson's disease. The next crossroad is to look at the cerebellum and its input like vision, eye test, vestibular system examination. Check rapid eye movement, coordination test to confirm or exclude cerebellum lesion. The loss of proprioception suggests posterior column disease, confirmed with Romberg test, check B12 level, and FTA antibody for syphilis for Tabes dorsalis myelopathy. Here is a little extra reading if you are interested. In this picture is a cross-section of spinal cord showing the major ascending and descending pathway. This will be useful if for localizing the posterior column and a lesion that can affect balance. This presentation purpose is to give your thinking process when you encounter a person who worries that he or she might fall. This presentation is not meant to be a tool that you use to diagnose your patient with. You will need to exercise clinical judgment and consider the clinical context of your patient presentation to make an accurate diagnosis. Thank you very much.